respiratory pathology. So far, you have discussed some of the commonest disease which we encounter during our practice. Those are bronchial asthma, then chronic obstructive pulmonary diseases, out of which chronic bronchitis and emphysema are very common presentation of the chronic obstructive pulmonary diseases. Then you also learned something about the bronchiectasis. This is the infectious, severe, persistent necrotizing infection causing destruction of the bronchial. The patient will have like repeated attacks of lower respiratory tract infection, thick purulent sputum production, and very debilitated. These patients are very weak, like they have high chances to go into the septicemia. Then you discuss something about the restrictive. We have the one pattern is obstructive and the another one is restrictive. You talk something about the restrictive lung diseases as well. Okay, now we are into the third part of the respiratory pathology. So what are we going to discuss over here? Again, in this lecture also, we are going to discuss the commonest diseases. In all these three respiratory pathology lectures, we have just touched the commonest diseases. We have not gone in details about some rare diseases, but because of the time and your course specification, we just have discussed about the common respiratory diseases. So in this lecture, we are going to talk about two things. One is pneumonia. So what is pneumonia? What are the causes of the pneumonia? Its pathogenesis, pathological changes, clinical presentation, and complications of pneumonia. Then, I'm sorry, we are also gonna talk about the knowledge of smoking related lung diseases. See what do we mean by the smoking related lung diseases? So you must be getting some confusion about it. Okay, doctor told about the COPD, especially chronic bronchitis, emphysema. These are the related to the smoking. Okay, but apart from those diseases, we are going to talk two diseases which are specifically related to the smoking. You can see emphysema in non-smokers. You can see COPD in the non-smokers. But these two diseases which we are going to discuss under this heading will be specifically seen in smokers. You don't find these diseases in non-smoker. But as we say, bronchial asthma, chronic obstructive pulmonary diseases, they are strongly associated with the smoking. Even the lung cancer is strongly associated with the smoking. But lung cancer can also be seen in non-smokers. Same goes with the bronchial asthma, emphysema, and chronic bronchitis. They are more commonly seen in the smokers, but they can be seen in the non-smoker. But these smoking-related lung diseases, these are specific to the smoking and they see in the smoking. So if you get a question, something like mention two smoking-related lung diseases, so you have to write only those two diseases. You don't need to write, even if you write the lung cancer, if you write the bronchial asthma, emphysema, you may argue that these are the correct. Yeah, they are related to, but when we ask about the specific smoking related lung diseases, you have to write about those two diseases only. So now coming to the pneumonia. Pneumonia is a very common disease. It can affect any age group from newborn to 100 years old person. Okay. So what do you mean by pneumonia? Pneumonia or pneumonitis is an inflammatory condition of the lung parenchyma. So it is an inflammation of the alveoli and the alveolar spaces and other lung parenchyma. Okay. What happens in the pneumonia? There is abnormal filling of the alveolar spaces. Okay. So what this abnormal filling? This abnormal filling is mostly a fluid, a edematous fluid due to inflammation. Whenever there is an inflammation, there is increased vascular permeability, and there is inflammatory markers that will bring about the fluid inside the alveolar space. So that will provide very less space in the alveoli for the gases to exchange. So these patients will present with the severe hypoxia. So in pathological terminology, you call either consolidation of the lung or exudation in the lung parenchyma. Consolidation also used as a radiological terminology. The word itself is self-explanatory. Lung is a elastic tissue. It has lot of air inside. It is not a solid one. When there is pneumonia occurs, there is accumulation of the fluid, and these accumulation of the fluid make lungs heavy and solid. That's why we call it as consolidation of the lung. Okay, are you following me?
Yes, we're with you.
Okay, so far it is clear what is pneumonia and when do you call consolidation? Consolidation is a clinical terminology most commonly used as a radiological feature. When you see a X-ray, you say, look, your consultation might tell you, look, is there any consolidation? So when you say consolidation, immediately it comes to your mind, Dr. Irfan has told in your second year pathology lecture that consolidation is a feature of pneumonia. Okay, never ever forget this term. Okay, consolidation is always related with the pneumonia, or any other, some other condition also can lead to consolidation, but in general it is related with pneumonia. Okay, pneumonia and influenza. Generally influenza, you know, the flu, which is if the person's immunity is not good, it will set up into the pneumonia. It is the sixth leading cause of the death. See, in sixth leading cause is very common cause of the death. Okay, it is in the top 10 cause. Okay, and as I told you, it can affect from any age group. It can also affect any race and any sex. Okay, there is no difference between the Asian, the European, or the Americans. Each and black race, white race, Indian, Saudis, Pakistanis, all will get affected with the pneumonia at an equal rate. Okay, and there is also no difference between male and female, and it is the single most common cause of infection related mortality. Okay, when you talk about infection, so most commonly it is pneumonia which leads to death. Pneumonia, septicemia, respiratory failure, pneumonia in case of influenza, pneumonia in cases of the complicated diabetic person, pneumonia in a immunocompromised person, pneumonia a person who is taking chemotherapy, all in turn lead to the severe pneumonia, septicemia, and death. And that rates increase with the comorbidity. What do you mean by comorbidity? Associated disease condition, such as someone who is diabetic or is on the chemotherapy or the steroid. If he get pneumonia, there are high chances he will develop into the severe pneumonia, and that may lead to death. So comorbidity and the age. What age group are more prone to cause death in pneumonia? The extremes of the age. Too much old and too much young. Premature babies, neonates, infants, children. As you go, elderly people, more than 70, more than 80, more than 90. So extremes of the age and comorbid conditions, associated diseases, immunocompromised status will increases the chance of death in pneumonia. So there are certain definition we use in pneumonia. What are these definitions? Community acquired pneumonia. Okay, so what do you mean by community acquired pneumonia? It is pneumonia or lung infection in otherwise healthy individuals, and it is acquired from the normal environment. A healthy person in a normal environment, okay, if he gets pneumonia, we call it as a community acquired pneumonia. You have, what is the simple presentation over here? Patient will have cough, fever, sputum production, uh, lung infiltration or consolidation in the lung, and the infection is related to the community. What is the infection common in the community? That infection you see in that person. Okay, right now it is going on influenza. So if someone get pneumonia, influenza associated pneumonia, it is community acquired pneumonia. So healthy individual acquired in the normal environment. Okay, this is called community acquired pneumonia. Now, healthcare associated pneumonia. What do you mean by healthcare associated pneumonia? Pneumonia that develops within 48 hours of the admission in patient list. Okay, someone, if you admitted a person in the hospital and he develops pneumonia within 48 hours, okay, within 2 days. And in what condition? There is a hospitalization in acute care hospital for more than 2 days. Yes, Omar, you have any question?
Uh, yeah, for the 48 hours. Is it before or after? Because I think I
Within,
heard in
within,
another
within,
lecture after.
within.
Within? So
Yeah,
before the 48 hours. Okay.
yeah. Within means 0 hour to 48 hours.
Okay.
Understood? So within
Yeah.
48 hours, hospitalization, if your patient has history of hospitalization in acute care hospital for more than 2 days in past 90 days. If your patient is a resident of long-term care facility, suppose he is on the rehabilitation program or he is in the mental health program, something he is residing in the long-term healthcare facility. If your patient is on the chronic dialysis within 30 days, or if your patient is receiving home IV therapy, home wound care in past 30 days, or if your patient has a family member with multi-drug resistance pathogen or bacteria. Okay, so in these condition, if a person got admitted and develops pneumonia within 48 hours, we call it is healthcare associated pneumonia. Okay, then there is a hospital acquired pneumonia. What is hospital acquired pneumonia? The pneumonia which occurs more than 48 hours, okay, or after 40 hours, 48 hours after admission. Okay, so suppose I admitted today 8 a.m. and I developed the signs of pneumonia, like today's first, second, third, after 8 a.m. of the third. So I have passed 48 hours in the hospital and I develop pneumonia, then you call it is the hospital acquired pneumonia. But I admitted in the pneumonia hospital at the time of admission, I did not have pneumonia, but I developed pneumonia within 48 hours. Okay. And I had a history. What kind of history? Especially, I have been hospitalized for more than 2 days in last 3 months, residence in long-term care facility, chronic dialysis, either I have received home IV therapy, home wound care, or I have a family member with MDR pathogens. In this condition, we call it as the healthcare associated pneumonia. Yes, someone has questions?
Yes, doctor, you hear me?
Yeah, yeah, I hear you.
I didn't understand what difference between within 40 hour and after 40 hour.
Yes. See, within 48 hours, pneumonia, especially if this is in this condition, so we call it is healthcare associated. Suppose, see, this patient has been hospitalized in the last 3 months for more than 2 days. So he has received some kind of healthcare, okay, in the past 3 months. And he has developed pneumonia within 48 hours. We call it as a healthcare associated pneumonia. This is also in the healthcare facility. He develops pneumonia within 48 hours. Healthcare. Chronic dialysis also he is related with the healthcare facilities. Same with the home IV therapy, home wound care in past 30 days. He has received healthcare in past 30 days. Or he has a family member with MDR pathogen. So all this condition, when he has pneumonia within 48 hours, we call it healthcare associated pneumonia. While hospital acquired pneumonia can happen to anyone, but the time duration should be less than more than 48 hours. Sorry. So hospital acquired pneumonia can happen to anyone who has been admitted to the hospital and he develops his symptoms, sign and symptoms of pneumonia after 48 hours of admission. So you call it as hospital acquired pneumonia. While ventilator associated pneumonia, if a person who put on ventilation or intubation, okay, and he develops pneumonia after 48 hours, you call it as a ventilator associated pneumonia. Understood?
Doctor,
Yes, yes.
so the only difference between hospital acquired and healthcare associated is the timing?
Timing and these conditions. Okay. If you don't meet with this condition, you don't call it as a healthcare associated pneumonia. Okay. You have patient must have something health related problem. So you have your patient, as I explained just now, your patients have received some kind of health care, either past 90 days admission, or he is in the residential health or long-term healthcare facility, or dialysis within 30 days, home IV therapy. Sometimes patient discharge at home from hospital and they just say take this injection IV, or dressing at home within 30 days. Something it is related to the healthcare and he develops within 48 hours. It is healthcare associated pneumonia. Hospital acquired pneumonia can happen to anyone. Here we don't have any categories of like this. Okay. It can happen to these patients. It can happen to the normal patients as well. Okay. But the time is 48 hours. To one extent, your doubt is clear. The main difference is 48 hours. It is less than 48 and the more than 48 hours. But to call it a healthcare associated pneumonia, you must fit apart from this time. There has to be these one of these category. Okay.
Yes, okay, doctor.
Okay.
Doctor,
Yes.
sorry, but health care associated pneumonia may
Yes.
occur outside the hospital, but related to this condition like this.
Yes. Yeah. So this patient might have had pneumonia because of any one of these condition. He has been admitted to the hospital and within 48 hours he started to develop pneumonia. We call it as healthcare associated pneumonia. So it is mainly related to some of his health conditions. While hospital acquired pneumonia can happen anyone. I am absolutely fit and fine. Alhamdulillah. I have not received anything. I have been admitted to the hospital just for the emergency appendix surgery. Okay. My surgery is over. Okay. And I have been also discharged also from the hospital next day. And after next day, say suppose after 48 hours of my surgery or 3 days after my surgery, I develop pneumonia. So my pneumonia is hospital acquired pneumonia. Getting, I am absolutely fine. I have been admitted to the hospital and I developed pneumonia within 48 hours. So my pneumonia could be community acquired pneumonia because at the time of admission, I might not have the pneumonia because if I don't have any of these conditions, if I fit any one of these conditions and I develop pneumonia within 48 hours, so definitely it is a healthcare associated pneumonia. But I don't have anything. I got admitted in the hospital. Okay. And I shows a sign of, or suppose some patient was walking on the road, he fell down, he got a head injury, you admitted him, and next day you find he is having high grade fever and all. You go his for the history, everything was neither had been advised, not in the long term facility, no dialysis, no IV therapy, nothing like that. So we can call it as a community acquired pneumonia. But if the same patient developed the pneumonia after 48 hours of the admission, it is hospital acquired pneumonia. Understood?
Yes, doctor.
So for healthcare associated pneumonia, one thing is it should be within 48 hours of admission, but at the same time, you must have one of these to call it healthcare associated pneumonia. Okay. If someone develop pneumonia within 48 hours of the admission, doesn't have any one of these things, he might be having community acquired pneumonia. Or any one of even these patient or a normal person develop pneumonia after 48 hours, it is hospital acquired pneumonia. If a person put on ventilator and show sign and symptoms of pneumonia after 48 hours of the start of ventilation, it is ventilator associated pneumonia. Okay. Yes, Muhammad.
Just I'm gonna ask about the BTS prevention in the line and the under the healthcare
Patients. This is
associated pneumonia.
patients. PTS is patients.
Okay.
That is short form for the patients. You must learn these short forms. When you go to the rounds, Dr. Tak, patients had history. So you cannot write patients had history of fever. PTS H/O fever. So it's a patient. MDR is multi-drug resistant. Okay. Okay. Shall I move to the
Okay.
next slide? Okay then. So what are the risk factors for the pneumonia? So see, pneumonia does not occur just like that, okay, because alhamdulillah, subhanallah, we have been provided with a very good defense mechanism which prevents lodging of the bacterial pathogen or viral pathogen or any microbial agent going and sitting into the deep in the lung and causing pneumonia. We have a lot of defense mechanism, and any of these defense mechanism is get defected or impaired, or there is something like this, like the resistance to the host is lowered. Resistance to the host is lowered, like suppose your patient is having diabetes, or your patient is on the chemotherapy, your patient is HIV positive, anything like systemic, his immunity is lowered, there is high chance of this thing. So there is local defense mechanism when there is a defect in the local defense mechanism, or there is systemic resistance or systemic immunity is lowered. So in that condition, you develop pneumonia. So loss or suppression of the cough reflex. Okay. Whenever any foreign particles, anything which try to enter into our respiratory tract, we suddenly get cough. This is a protective reflex of the body, which is known as the cough reflex. Okay. But this cough reflex get lost or suppressed as a result of the altered sensorium or altered consciousness, such as in case of the coma, in cases of the anesthesia, neuromuscular disorders, stroke. So in this condition, there are high chances of the aspiration of the gastric contents. That's why anytime before surgery, your patients, you ask your patient not to eat at 8 to 10 hours before surgery, anything, even not to take water. Okay, so they should be totally empty stomach. So the gastric content should not come into the mouth, and from mouth it should not go into the lung, because aspiration is one of the common cause for the pneumonia and the respiratory failure. As we last time also we discussed, gastric aspiration is the commonest cause in for the acute lung injury or the acute respiratory distress syndrome. So loss or suppression of the cough reflex, it can happen either in the coma, loss of consciousness, anesthesia, a stroke, neuromuscular disorder. So it might lead to aspiration of gastric content, and these gastric content will lead to progression of the bacteria in the lung. Dysfunction of the mucociliary apparatus. Respiratory tract epithelium is pseudostratified ciliated columnar epithelium. So cilia, you know better than me the functions of the cilia. So whenever this ciliary function is lost, It could either happen by the cigarette smoking or some inhalation of the some hot or toxic gases, certain viral infection, certain genetic disorder of the cilia function like immotile cilia syndrome or the Carter-Jenner syndrome. So these cilia become defective. They are not able to clear the pathogens or microbial agents at the same time the mucus excessive mucus present, because mucus has to come out. If mucus remain in the respiratory tract, it is a very good ground or culture media for microbiological agents to grow. So anything dysfunction will lead to high risk of pneumonia. And then the accumulation of the secretion. So in the cystic fibrosis and the bronchial obstruction, there is accumulation. The secretion is not coming out. They are accumulated at the same place. So again, secretion is very rich in protein and glucose. So very good culture media for pathogens to grow. Then systemic defense mechanism like interference with the phagocytosis and bactericidal activities of the alveolar macrophages. How it can happen? It can happen alcoholism, smoking, hypoxia, oxygen intoxication. So these alveolar macrophages will not function, so they will not kill the bacteria or viruses in the lung. So there are high chances of bacteria and viruses to grow because the phagocytic mechanism is not working properly. Whenever there is a pulmonary congestion or edema, any condition which lead to the pulmonary edema or congestion like congestive heart failure, so there is fluid in the lung. Whenever there is a fluid will provide a culture media for bacteria or any viruses to grow inside the lung. So these are the risk factors. So there is a local defense mechanism dysfunctions. Okay. Any questions? Okay. So what are the types of pneumonia? We can classify pneumonia in a broad way. Microbiological, it is viral pneumonia, bacterial pneumonia, fungal pneumonia, tuberculosis pneumonia. We can have like non-infective one, toxin-induced pneumonia, chemical-induced pneumonia, aspiration pneumonia. Yes, Zainab, you have any question?
Yeah, doctor. In the
Yes,
previous
please.
slide, you mentioned anoxia. What is the difference between anoxia and hypoxia?
Yeah,
Anoxia.
anoxia and hypoxia is like anoxia is near complete lack of oxygen. Okay. Some people call it is anoxia, some people call it is hypoxia. Okay. So here anoxia means it is a hypoxia, but a severe type of hypoxia. Okay.
Okay. Okay.
So, so non-infective if you someone has aspirated something like gastric aspiration, so gastric aspiration pneumonia, someone aspirated some chemical or chemical inhalation of the chemical or toxins. This is a non-infective type of pneumonia. Then pathological and morphological type. If the entire lobe is affected of the lung, we call it as the lobar pneumonia. If the multiple areas are surrounding a tracheobronchial tree, we call it as the bronchopneumonia. And if the interstitial of the lung is affected more than the alveoli, we call it as the interstitial pneumonia. Then we have the duration. If suppose it is a very short duration, acute pneumonia. For a long period of time, chronic pneumonia. We have clinical also, primary pneumonia, secondary pneumonia, typical pneumonia, atypical pneumonia, community acquired, healthcare associated, hospital acquired, ventilator associated. Okay. So these are the causes of pneumonia syndromes. Okay. So community acquired pneumonia. So you have most common bacterias for the community acquired pneumonia is Streptococcus pneumonia, Haemophilus influenza, Moxirilla catarrhalis, Staphylococcus aureus, Legionella pneumophila. Okay, but among these, the top four are the most commonly commonly known bacteria to cause community acquired pneumonia. Okay, then you have like um, chlamydia, mycoplasma, viruses, respiratory syncytial virus, especially the young children, influenza, parainfluenza, COVID, adenovirus. These are all the community acquired. Then healthcare associated pneumonia. Healthcare associated pneumonia, you have either MRSA or methicillin sensitive SRA, Pseudomonas and the Pneumococcus. Hospital acquired, usually caused by the gram negative rods like Klebsiella, Serratia, Pseudomonas, and the Staphylococcus, especially the methicillin resistant Staphylococcus pneumonia. Aspiration, you get in the aspiration pneumonia generally the anaerobic oral flora, because the aspiration goes through the oral cavity. So these oral bacteria, especially the anaerobic bacteria, grow. Chronic pneumonia, generally fungal or like special type of pneumonia, nocardia, actinomyces, the tuberculosis, especially granulomatous, you have tuberculosis, atypical tuberculosis, histoplasma, necrotizing pneumonia, and lung abscess, necrotizing bacteria, especially Staphylococcus aureus, Klebsiella pneumonia, Streptococcus pyogenes. This pyogenic bacteria causes lung abscess. And immunocompromised host, you have special type organs like cytomegalovirus, Pneumocystis jirovecii, Mycobacterium avium intracellular complex, invasive aspergillosis, invasive candidiasis. Okay, these are you see in the immunocompromised host. So what you have to, this not very necessary to remember this, because the important things I will going to discuss again. But a rare condition, very, very rare condition, they might ask you like, what is the common organism you see the aspiration pneumonia? So anaerobic flora, commonest bacteria for the community acquired pneumonia. Just remember these four names, okay? Healthcare, generally Staphylococcus and MRSA and non-MRSA. Hospital acquired E. coli, Klebsiella. Okay, so these are the important thing to remember. So how what is the pathogenesis or how pneumonia occur? So bacterial infection generally follow an upper respiratory tract. Okay, viral infection, generally a person have first the viral infection, and this viral infection will lead to development of the secondary bacterial infection. Okay, and especially on which condition, like extremes of the age, someone who's having chronic diseases such as congestive heart failure, COPD, and diabetes, congenital or acquired immunodeficiencies like HIV, or congenital defects in the phagocytosis, and like if there is no spleen or absent splenic function, it will especially lead to the encapsulated bacteria, especially the pneumococcus. So any person who underwent splenectomy or removal of the spleen, he has to take mandatory pneumococcal vaccination, because if he doesn't take this capsulated bacteria can cause severe pneumonia, because spleen is a very important organ in killing the capsulated organs. Bacterial invasion of the lung parenchyma causes the alveoli or alveolar space to be filled with an inflammatory exudate. So whenever there is a inflammation of the lung parenchyma, there is increased vascular permeability, increased accumulation of the fluid in the alveolar spaces. So elastic air-filled alveolar spaces change to the solid fluid-filled spaces with very less place for the gas and air exchange, and this lead to the consolidation or solidification of the pulmonary tissues. So bacterial pneumonia, especially these morphological changes, are more characteristic with the bacterial pneumonia. We have the two anatomical distribution, lobular or bronchopneumonia. When you see the patchy areas of consolidation along a bronchi, you have a bronchi surrounding lung parenchyma show a patchy area throughout the lung. Sometimes it is more in the upper lobe, sometimes it is more common in the lower lobe, or sometimes entire part. It is known as the bronchopneumonia or the lobar pneumonia, when there is a consolidation of the large portion of a lobe or an entire lobe, as you see over there. Okay, and in the lobar pneumonia, you see the four stages of the inflammatory response. These four stages of the inflammatory response is very, very important because you see beautiful histopathological and gross changes in the lung. And what are these four stages are? Congestion, red hepatization. Okay. See, what do you mean by hepatization? Because lung is a elastic organ. When it becomes solid, it looks like a liver. So we call it as a hepatization. In the initial phases, congestion. After congestion, there are a lot of RBCs in the lung parenchyma. So it looked like little bit red in color. So we call it as a red hepatization. Later on, these RBCs get cleared by the macrophages and there is more fibrin deposit. So it colors look gray in color. So we call it as a gray hepatization. And the fourth phase is a resolution. Okay. So this is the four phases. Very, very important you to remember this name. Okay. Congestion, red hepatization, gray hepatization, and resolution. For more detail, we will discuss this in the practical slides. So, morphological differences between bronchopneumonia and the lobar pneumonia. Bronchopneumonia is like at the extremes of the ages, okay, while the lobar pneumonia is usually seen between the middle age group, 20 to 50 years, okay. Bronchopneumonia is usually associated with the secondary, someone who is already suffering from some diseases like COPD, bronchial asthma, or diabetes mellitus, okay, or some immunocompromised stage, okay. But while the lobar pneumonia usually seen as a primary lung infection in a healthy person. Okay, both genders are affected equally in the bronchopneumonia. Males are more common in the lobar pneumonia. Bronchopneumonia, the common organism of the Staph aureus, Streptococcus pneumonia, Haemophilus influenza. While the commonest organ isolated from the lobar pneumonia is Klebsiella, gram negative. So bronchopneumonia is mainly gram positive, while lobar pneumonia is mainly due to the gram negative. Here you see the patchy area of consolidation. There is no limitation by any anatomic boundaries and it could be bilateral. Okay. Here you get entire lobe consolidation or a large area of a lobe or entire lobe. There is diffuse involvement of the lung parenchyma and the consolidation is demarcated by like or limited by the anatomic boundaries. Anatomic boundary of a left lower lobe or right lobe, middle lobe, it is demarcated by this boundary and it is usually unilateral. Here what is you see inflammation which is suppurative associated with necrosis. Okay, so there is suppuration like a lot of pus, neutrophils, and necrosis. There is more complication is bronchopneumonia because it is see it extremes of the age, secondary to any other diseases. So you have and bilateral, so there are more complication. Here inflammation is acute fibrinous. Okay, acute fibrinous non-suppurative. So here you have a lot of fibrin deposit, lot of macrophages, less neutrophils, okay, and less complication because it is in relatively good age group, healthier persons, okay, and limited with the anatomical boundary, less chances to go to the systemic circulation. Okay, so this is the difference between bronchopneumonia and the lobar pneumonia. So what are the clinical features of the pneumonia? So what are the main symptoms of the pneumonia? One of the commonest symptom of the pneumonia is high fever, cough, and sputum production. This is first any person comes with this and it's not responding. You need to look for an X-ray and rule out pneumonia. So we have systemic high fever, chills, cough with sputum or phlegm. Phlegm is nothing but the very purulent sputum, shortness of breath, pleuritic chest pain. What do you mean by pleuritic chest pain? Can anyone explain to me what is pleuritic chest pain?
تهيج.
Yes.
Like
Yes,
coughing
yes,
due
you are
to
correct.
coughing due to the I didn't know how can say it in English, but it's
Okay,
تهيج
I
normally.
will say pain while coughing or breathing. When you breathe or you cough, you get a sharp pain in the chest. that is known as pleuritic chest pain. Okay, and very characteristic feature of the pneumonia. And you also can differentiate this chest pain from the MI. Myocardial chest pain will not relate it to the breathing and coughing. But if your patient say I have chest pain and I feel very sharp, pricky pain while coughing or while taking a deep breath, it is a pleuritic type of chest pain. You must look for the either the viral infection or pneumonia. Sometime rarely your patient might have hemoptysis. If the inflammation is severe, very necrotic, it invades surrounding blood vessel. So patient will have blood in the, this is a generalized fever of the infection like fatigue, aches. Yes, Zainab.
Uh, Doctor, does it indicate a problem in the pleura?
Yes, because along with the lung parenchyma, the covering visceral and the parietal pleura also get infected and inflamed. So you get the pleuritic type of chest pain. And you will have the other symptoms of the infection like muscles, fatigue, muscle pain, joint pain, nausea, vomiting, because the patient has high inflammation and fever. So other features of other associated symptoms with the fever, you might have high heart rate, because if the patient has very large area of the lung involved, he might have the tachypnea or dyspnea, headache. Okay, so these are all the features of pneumonia. Complications of the pneumonia. Locally in the lung, there is lung abscess formation. If this abscess goes into the pleural cavity, there is collection of the pus in the pleura, pleural cavity, empyema. If the patient pneumonia doesn't resolve, it lead to the intra-alveolar scarring and fibrosis. That also might lead to the restrictive lung diseases. If the severe pneumonia lead to the bacteremia, and the bacteremia may cause septicemia, that will lead to the infective endocarditis, abscess in the brain, inflammation of the meninges, or septic arthritis. Okay, so these are the complications of pneumonia. So now we have community acquired pneumonia, two types. One is typical and atypical. As I told you, this, if you go this slide, this is the four causes of the bacteria. These are the community acquired typical pneumonia. While you come these three causes, these are the community acquired atypical pneumonia. Okay. So, so why you call it is a atypical pneumonia? Because there is not much sputum production, not much physical finding, like not much fever. You don't find any like other findings of infection, not very high elevated WBC, which is usually associated with the typical pneumonia. There is no alveolar exudate, no much consolidation, but alveolar septum and interstitium will be more involved over here. Okay, exudate will be less, but the septum and interstitium will show inflammation. Okay, so that's why it is called community acquired atypical pneumonia. So this is not typical. So we'll not find the findings of the typical pneumonia. So not much sputum production, not much physical sign, not much elevated WBCs, not much alveolar exudate, or much of alveolar septum and interstitial infiltrate. So you have this mycoplasma, viruses, chlamydia, and coaxial. And among these, mycoplasma is the most common cause for the community acquired pneumonia. And the most common cause of the community acquired typical pneumonia is pneumococcus or streptococcus pneumoniae. So most common cause of community acquired atypical pneumonia is mycoplasma. Most common organism for the community acquired typical pneumonia is pneumococcus or streptococcus pneumoniae. So morphology will be patchy, interstitial infiltrate, while there is neutrophil and macrophage are the more important cell. Here you see the lymphocytes. There is pleura involvement is very common in the community acquired typical pneumonia, while in the atypical pneumonia, pleura is free. So what are the key concepts of the pneumonia? Streptococcus pneumonia or the pneumococcus is the most common cause of the community acquired typical acute pneumonia. And the distribution of inflammation is usually lobar. Lobar pneumonia evolved through four stages: congestion, red hepatization, gray hepatization, and resolution. Bacterial pneumonia are characterized by predominantly intra-alveolar neutrophilic inflammation, while viral pneumonia or atypical community acquired pneumonia shows most of the lymphocytic inflammation infiltrate, and that is in the interstitium, not in the alveolar. Other common cause of the acute bacterial pneumonia is H. influenza, Moxarella catarrhalis. Okay, and these are usually associated with the exacerbation of the COPDs, Haemophilus influenza and M. catarrhalis in the exacerbation of the COPD. Staph aureus is usually following a viral respiratory infection. First, the person get viral respiratory tract infection, and if he develops pneumonia, it is usually by the Staph aureus. Klebsiella pneumonia in the patient with the chronic alcoholism. Pseudomonas aeruginosa, cystic fibrosis. Legionella pneumophila, usually person who are having the other comorbidity condition like heart or lung diseases or in the organ transplant recipient. Viral are the influenza, meta pneumonia virus, like generally now they are talking about in China, HMPV, human meta pneumonia virus. Okay, this is not new, it is always there, and the always happen during the winter periods. Okay, and the our best friend COVID. Now, as I told you, the smoking related lung diseases. Okay, so you have smoking related diseases into the obstructive diseases like the emphysema, chronic bronchitis, and the restrictive or the interstitial lung diseases. And idiopathic pulmonary fibrosis, also a majority of the patients are smokers. So smoking causes many diseases in the lung. Even the lung cancer is also associated with the smoking. But there are very important smoking related lung disease, and these diseases are specifically related to the smoking. What are those? Disformative interstitial pneumonia and the respiratory bronchiolitis associated interstitial lung disease. So what is disformative interstitial pneumonia? It is characterized by a large collection of the macrophages in the airspace of a current or former smoker. So in the alveolar spaces, you find the large collection of the macrophages. The macrophages were originally thought to be the desquamated pneumocytes. They thought like they are the pneumocytes which has shedded from the epithelium, alveolar epithelium, and lodged into the alveolar spaces. So that's why initially the misnomer was known as the desquamative interstitial pneumonia. But this is not the alveolar pneumocytes or alveolar epithelial cell. Instead, they are the macrophages, and they are seen in the alveolar spaces in the smokers, and usually seen in the fourth or fifth decade of the life, equally common in men and women. And you have the insidious onset of breathlessness, like slowly progressive breathlessness, dry cough for a period of weeks and months, and you also have the clubbing of fingers. And pulmonary function tests have the restrictive abnormalities. Okay, and they have a very excellent response to the steroid therapy and the cessation of smoking. They stop smoking and take the steroid, they get very good response, but very rarely some patient might progress to the interstitial fibrosis. So this is the specific disease specifically seen in the squamous, and you have the macrophages in the pneumonia, and there is an insidious like slow onset of dyspnea, chronic cough for the week and months. You don't find anything like COPD feature or pneumonia. Instead, lung biopsy shows lot of lung macrophages in the air spaces. Okay, and if you give patients steroid and ask them to stop smoking, majority of patients respond well with a very good recovery, and some patient might develop interstitial fibrosis. The another disease is the respiratory bronchiolitis associated interstitial lung disease. So there is marked inflammation of the marked by chronic inflammation and peribronchial fibrosis. So there is inflammation and peribronchial fibrosis. And it is common histological lesion you see in the cigarette smokers. There is pigmented intraluminal macrophages within first and second order respiratory bronchioles. So there you see the macrophages in the alveolar spaces. Here you see the pigmented macrophages first and second order respiratory bronchioles, not in the air spaces. Mildest form, like if patient doesn't have anything, you took the biopsy for some other reason and you find the incidental finding, okay, in the smokers and the ex-smoker. And if the person develops significant pulmonary symptoms, abnormal pulmonary function test, abnormal imaging abnormalities, okay, so you give the terminology respiratory bronchiolitis associated interstitial lung disease. And here, just if the you ask them to stop smoking, and patient will show the improvement. Okay, these are the two smoking related diseases. Now we go for the lung cancer. Okay, lung cancer is currently the most frequently diagnosed major cancer and the most common cause of cancer mortality worldwide. Okay, so most common cancer and most common cause of cancer mortality. Okay, there was 2.1 million new cases and 1.8 million lung cancer deaths. See, 2.1 and 1.8 million. So mortality is almost, you see, 100% mortality over here. Okay, so or more than 80% mortality. Okay, and it is 14% of the all cancer diagnosed and 28% of the all cancer related death. And each year, lung cancer kills more people than the colon, breast, and prostate cancer combined. So suppose you have 100 colon, 100 breast, and 100 prostate cancer dying, you will find more than 300 patients die due to the lung cancer. It is usually a disease of the older adults, commonly seen between 55 and 84 years of the age. Between 65 and the 75 years shows the peak incidence, and very rarely you see cases less than 40 years of the age. So that's why lung cancer is so common, smoking is so prevalent, okay, and the death is so common with the lung cancer. So we must know about what is lung cancer, a few thing about the lung cancer. So what causes lung cancer? Smoking. 80% of the lung cancer occurs in active smoker or those who stopped recently. And you have the 60 times greater in habitual heavy smokers. And women are more susceptible to carcinogen in tobacco than men. So if a woman is smoking, she is more susceptible to develop lung cancer than a similar age group men. Okay. And the smoking most commonly causes small cell carcinoma, then the squamous cell carcinoma, then the adenocarcinoma. So the type of lung cancer strongly associated with the smoking is small cell carcinoma. Okay. As they say, the most common cancer in the smokers is small cell carcinoma. And the most common cancer in the non-smoker is adenocarcinoma. Okay. This is the commonly asked question in both undergraduate, postgraduate, or if you write SMLE, PLAB, or USMLE. So one of the commonly asked questions. The commonest cancer associated in the smoker, small cell. Commonest cancer associated with the non-smoker, adeno. Industrial hazards like exposure to the industrial toxins like the asbestos, arsenic, chromium, uranium, nickel, certain dye, vinyl chloride, which we use plastic and the latex industries, radiation. So those who are working in the radiology department, those who are exposed to the uranium mining or the nuclear exposure, they all are known to develop lung carcinoma. Air pollution is the commonest cause of the development of the lung carcinoma. That's why they say like no, even non-smoker develop lung cancer. So other could be some pollutants in the air. And the molecular genetics. Genetics play a very important role in the lung cancer, and they are so important now. They are identifying the individual gene and getting a targeted therapy, killing the or targeting the specific gene which get defective in the lung carcinoma. So what are these genes are? EGFR, ALK genes, or tyrosine kinase receptor gene in the adenocarcinoma. So nowadays, the research are going on to find out the drugs which targets these genes so that the carcinomas can be treated. Squamous cell carcinoma, you have P53, cyclin dependent kinase inhibitor, P16, small cell carcinoma, c-MYC gene, and the RB gene. So nowadays, cancer is a genetic disease, and now all the research is directed towards find out the commonly affected gene and find out the targeted therapies against those genes. So we'll come to the classification. We have a lot of histological classification for the lung carcinoma, but we need the clinically significant classification are this: adenocarcinoma, squamous cell carcinoma, small cell carcinoma, large cell carcinoma, and the other. And among these, most common are the adenopathy. Initially, they used to say the squamous cell carcinoma is the commonest one. But the last 2 decades, the statistic has changed. Now the adenocarcinoma is the most common, followed by squamous cell carcinoma, small cell carcinoma, and the large cell carcinoma. Others are the lymphomas, neuroendocrine, or sugar tumors, and all the rare types are there in the others. Okay, and this is a big list. Okay, but at your level, you know these 4 type very well: adeno, squamous, small, and large cell carcinoma. So can you tell me which of these among these 4 associated with the smoking?
Small cell carcinoma.
Small
Small
cell
cell
carcinoma.
carcinoma.
Yes. So what is the morphology? Okay, lung carcinoma may arise in the peripheral of the lung. Okay, if it is the periphery, most commonly it is adenocarcinoma. Or if you see in the central or hilar region, it is most commonly the squamous cell carcinoma. So all these points are very, very important. A female, non-smoker female presented to the with chronic cough and sputum production, CT shows a small mass at the periphery of the lung. What is the most common diagnosis? Yes. So female,
Adenocarcinoma.
non-smoker, periphery, adenocarcinoma. Male,
Again,
smoker, near the hiral or central region, large, inside the bronchus, small squamous cell carcinoma. So what is adenocarcinoma? Is an invasive malignant epithelial tumor with glandular differentiation. Sometimes it also produces mucin. They grow in various patterns like acinar, lipidic, papillary, micropapillary, and solid. Okay, this is their like if they look like small glands, we call acinar. If they are lining the alveolar wall, we call it as lipidic. If they show the papillary formation, large papillae, papillary, they're very small papillary, micropapillary. If they don't show any pattern, we call solid. Okay. And compared to the squamous cell cancers, they are more peripherally and they tend to be the smaller. And I'll give you one more hint. It is more common in the non-smoker and especially in the females. Okay. Squamous cell carcinomas are often antedated by, or there is always a history of the squamous metaplasia or the dysplasia, especially in cases of the smoker. Smokers Due to the smoking, normal ciliated pseudostratified columnar epithelium undergoes the squamous metaplasia. If the smoking continues, it goes into the dysplasia and then go into the carcinoma in situ, where the malignant changes only seen in the epithelium, and these stages remain for a long period of time without any symptoms. Okay. Incidentally, for some investigation, you might diagnose at this stage, but very rarely. And when it progresses, then it shows presence of keratinization and intracellular breach. The small cell carcinoma, name itself suggests there's the cells are small, and it is a very highly malignant tumor and very strong relationship with the smoking. And you have like very small cell like lymphocytes, very little amount of cytoplasm, very ill defined cell borders. Nuclear chromatin is like very finely granular. It looks like salt and pepper when you mix, like that kind of appearance. Okay, so this is a microscopic appearance, salt and pepper pattern, small cell carcinoma. Okay. The cell could be round, oval, or spindle shapes. Large cell carcinoma, if it is not adeno, if it is not small cell carcinoma, if it is not squamous, we call it a large cell carcinoma. Okay. And it is, apart from morphology, it also does not show any immunological markers. Okay. So what adenocarcinoma immunological marker is TTF1 napsine. So this tumor is negative for this marker, negative for the marker for the squamous cell carcinoma like P40 and P63, even negative for the markers of the small cell carcinoma, chromogranin, cerebrotrophysin, and CD56. Neither it resemble morphologically nor immunologically to any of these. Okay. And why I have written, because TTF1 is a very characteristic marker for the adenocarcinoma. P40, P63 squamous cell carcinoma, and small cell carcinoma, chromogranin, synaptophysin, and CD56. So this is the morphology you have. Okay, we will discuss this in detail in the practical. I will not show much in detail about discussion over here. Okay, we'll discuss this morphological pattern in the practical slide. Okay, so how do it is spread? It can go to the mediastinum, from lung to the pleura, pleural space to the mediastinal step, nodes, peribronchial, hilar to the distance, also go to the pericardium, through lymphatic to the different lymph nodes like supraclavicular lymph nodes, or through the blood to the adrenals. Adrenals is the most common site for the metastasis for the lung cancer. Liver, brain, bone, any organ they can go. Clinical symptoms, you have cough, hemoptysis, chest weight loss, chest pain, breathlessness. You will also get the local effects due to tumor. Sometimes you get pneumonia, abscess, collapse of the lobe, pleural effusion, hoarseness of the voice if the recurrent laryngeal nerve is involved, dysphagia if the tumor is large, compressing the esophagus, diaphragm paralysis if the involvement of the phrenic nerve. If it comes towards the ribs and the surface, you get the rib description. If it is the upper part of the apex of the lung, it may cause the superior vena cava syndrome, Horner syndrome, involvement of the sympathetic chain, pericarditis, cardiac tamponade. These are all the local effect of the lung carcinoma. And this lung tumor also known to cause paraneoplastic syndrome. Paraneoplastic syndrome is due to the secretion of various hormone or hormones like substance by the lung tumor. Okay. So when the lung produces antidiuretic hormone, patient develop hyponatremia. And what is this tumor known as small cell carcinoma? Patient might also develop Cushing syndrome because of the ACTH or ACTH-like substance from the small cell carcinoma. Hypercalcemia is parathyroid hormone or parathyroid hormone related peptide, prostaglandin E, or some cytokines. So hypercalcemia is very common with the squamous cell carcinoma. While hyponatremia, Cushing syndrome, you have small cell carcinoma. You also get hypocalcemia when the tumor secreted calcitonin, gynecomastia when the tumor secreted gonadotropins, Carcinoid syndrome, when the tumor secretes serotonin or bradykinin. Lambert-Eaton myasthenic syndrome, when they secrete a- a- acetylcholine resembling antibodies. Okay. Peripheral neuropathies, acanthosis nigrosis, the black patches over the neck and the axilla and the groin, leukemoid reaction, like very high WBC count, hypertrophic pulmonary osteoarthropathy. Your patient will have the bony destruction in the wrist joint and the fingers. These are all the paraneoplastic syndrome. But remember these hormone and associated thing: ADH, hyponatremia; ACTH, Cushing syndrome; PTH or parathyroid or hypercalcemia; calcitonin, hypocalcemia; serotonin or bradykinin. So remember these higher hormones and this thing. To remember which tumor causes, so very important to know hypercalcemia is always associated with squamous cell carcinoma, and small cell carcinoma, okay, causes hyponatremia and the Cushing syndrome. Okay. How do you diagnose? You need to either with the X-ray chest, CT, MRI, positron emission tomography, or PET scan. You also take a cytological examination of the sputum or bronchial washing, affinity of the cervical lymph node, biopsy of the lung mass, immunohistochemistry, molecular tests. The prognosis is poor. 5-year survival rate is less 15%. But if you diagnosed earlier in the initial stages, small cell carcinoma, though it is a very high grade malignancy, but it has a response to the radiation and chemotherapy. So here we finish our respiratory pathology. I have to ask you one question. Now tomorrow we have practical. I have to take for both male and female. And this is gonna be online. So how do you want me to take?
Doctor, you mean the timing or what?
uh the practical timing. Yes, I want a timing because I want to, this is a simple practical. Okay. Like a PowerPoint presentation. We don't have any slides or specimen to show. We will show the images in the PowerPoint, images of different lung conditions, microscopic features, and the description, which I will show in the PowerPoint. Okay. So, and the same time for the male and female. Till the last year, we were taking at a time for male and female combined online. So both the leaders from the male and female decide a common time and let me know the time so that I can take your practical slide.
Okay, doctor.
Okay, you're understanding my point now. I have to take the group A for the male and female at the same time, which is not possible. Okay, so it's better for me to take like as a lecture, PowerPoint lecture combined for all the batches. Okay, if you have any free time tomorrow.
The leaders are going to communicate with you and tell you after they
Okay,
review it.
inshallah. Just whatever the thing is there, please let me know. Okay.
Okay.
If you have any doubt, please do ask me on my WhatsApp about today's lecture. Okay. So it's already, yes.
Just to make sure all the groups, males and females, will take the lecture together, right?
Yeah. That's why I'm telling you I need a common timing. That's why I like, so that all the male and female I take together. This is what I was doing till last year.
Okay, inshallah.
So just get me, yeah, get me a time according to your convenience. I will take the practical. Okay, inshallah. Decide among yourself, your leaders, and let me know the time. Okay, inshallah.